All right, we'll get started. So in our national meetings, there's this very popular talk every year where they talk about the most seminal or groundbreaking publications that have happened in the past year. I thought we'll do something similar, but instead of that, I picked events which happened in the past year, which I think is of interest to the general internist and which may affect your practice. So it's not any specific topic, it's kind of all the new changes in the past year. So if you look at the CDC website, they're always investigating outbreaks. This is the list of outbreaks in the past few months. It's the usual foodborne illnesses, which I won't talk about. But an important one in 2013 was the Serogroup B meningococcal disease outbreak in some college universities. So from spring of 2013 to late 2014, CDC along with the New Jersey Health Department and Princeton responded to an outbreak of meningococcal group B disease. Around the same time, there was a similar outbreak going on in Drexel University. A few months after that, there was a meningococcal outbreak in University of California, Santa Barbara. All three were unrelated. But what was common was they were all serogroup B meningococcal disease. And this led to, so everybody knows there are actually 4 serotypes, but 3 which circulate widely in the United States, B, C, and Y, which cause disease. So we've had meningococcal vaccine, but we didn't have a vaccine against serogroup B. There was a vaccine for serogroup B, which is available in Europe. And as part of response to this outbreak, they got an FDA investigational new drug, and on all these college campuses, thousands of people were vaccinated through that IND. This led to finally formal submission and approval of 2 new meningococcal B vaccine made by 2 different companies. They're both licensed for use in adolescents and adults from 10 to 25 years of age. One requires 2 doses, one requires 3 doses. So there was no routine recommendation to administer this vaccine at present, although it is FDA approved. In the February meeting of ACIP, they voted for the following indications. So this is not published yet. It's going through its approval process to be published in MMWR. But this is the recommendation. Who should get meningococcal B vaccine? People with persistent complement component deficiencies, anatomic or functional asplenia, microbiologists who routinely work with isolates or are potentially exposed to isolates of Neisseria meningitidis, or persons identified to be at an increased risk during outbreak of meningococcal disease outbreak. What was on the agenda to also discuss whether it should be routinely given, because we give the other meningococcal vaccine routinely to young adults. February 26 happened to be inclement weather, so that was deferred, and it's now on the table for discussion in the June ACIP meeting. So that recommendation may change towards the end of the year. So the last one begs the question, what is a serogroup B meningococcal disease outbreak? So when do we say it's an outbreak? Is it 1 case, 2 case, 10 cases, 1 fatality? So there is some guidance from CDC, and these were published while those outbreaks were happening. So it says through CDC-sponsored expanded access IND, but now it's FDA approved. But the principle's kind of the same. So you kind of look at your population. If it's less than 5,000 persons, if it's 1 case, do the serogrouping, type it, and save it. Don't have to do anything more than what we usually do, which is contact chemoprophylaxis and case investigation. However, if it's 2 or more cases in 6 months, that is considered an outbreak, and that is the time to consider using this vaccine. If the population is more than 5,000 persons, then it changes slightly, then it's 3 or more cases in 6 months. You do want to type all of those and save it, which is usually done by the health department. So don't discard those isolates, and if it's 2 or more cases, we can send those isolates to CDC to make sure that they match. So So right now, this is the recommendation to add it to your meningococcal vaccine for those high-risk groups, but keep your eyes open. It may be part of routine vaccination later. So around fall of last year, while we were all going to die from Ebola, there was a multi-state outbreak happening in the United States. This was summer and fall when we typically have enterovirus outbreaks. But what was unusual about this was there were 112 children in 34 states who developed acute flaccid myelitis, similar to polio presentation. And median age of children was about 7 years. Almost all of them were hospitalized. Some required ventilatory support. Most of them had some respiratory illness which preceded their neurological symptoms. The prognosis wasn't great. 2/3 had some improvement in symptoms, 1/3 showed no improvement, and only one child fully recovered. In a lot of these children, they were able to isolate enterovirus, which typed to enterovirus D68 from their respiratory samples, but of all these cases, only 2 they were able to isolate enterovirus from the CSF. So there's a suggestion that enterovirus D68 was the cause of myelitis, but we could not prove that it was definitely the cause. So this was a nice paper published a couple months ago in Lancet Infectious Diseases, and this kind of illustrates how we investigate diseases and demonstrate associations using molecular technology. So what these people did, they found some of these children who did have acute flaccid myelitis or aseptic meningitis, and they used next generation sequencing to try and find out if there is enterovirus D68, and then they did phylogenetic analysis to see if they were related, because remember, enterovirus is pretty common. So what they found, they had a bunch of subjects with acute flaccid myelitis, some aseptic meningitis or encephalitis, and these people had all tested positive for enterovirus. When they did their PCR, reverse transcriptase PCR, and their next generation sequencing, they were able to detect enterovirus in most of these patients, but in none of them were they able to detect it from the CSF. So it again shows putative association, but not definite causation. But what was cool about this, when they did the phylogenetic analysis, they found they all matched. So with enterovirus D68 is not a new virus. It had been present before, but it had never been shown to have any association with this neurological illness. So what the phylogenetic analysis showed, that even though it's a virus which was present earlier, there is a new clade B1 that emerged in 2012. And that is possibly the reason why we are seeing a different manifestation of the same virus. So I was talking with a faculty in the hallway some months ago, and we were talking about how there's declining interest nationwide amongst trainees in infectious diseases. And the faculty said, "Oh, I know why." And I said, "Why is that?" And he says, "Oh, that's because there are no new antibiotics and your diseases are all yucky." And you know who that is, Dr. Greenberg. Which is true. So there were no new antibiotics. So this is the antibiotic discovery timeline, and from 1998 onwards, we were in what is called an antibiotic discovery void, as in there were no new compounds being discovered. And you can understand why. When we do have new antibiotics, we say, "Oh, don't use it, save it for when we really need it." And then when you use it for the shortest possible duration, and maybe you don't need it at all. So you can see why there's no interest amongst the manufacturers to develop antibiotics. So to spur some antibiotic development, what was passed in the Congress was the GAIN Act, which is the Generating Antibiotics Incentives Now. And as part of this GAIN Act, this was to promote antibiotic development, or anti-infective development rather. These drugs were approved and are designated as qualified infectious disease product. And what does that involve? So as part of this QIDP designation, they get expedited drug review. then in addition to whatever the existing patent laws are, they get 5 years of exclusive marketing. As part of this, there has been at least 39 antibiotics which are under development. So there are 5 new antibiotics which were licensed in the past year that I'm going to talk about, 3 for gram-positives, 2 for gram-negatives. The first one amongst these gram-positives is Dalbavancin. So this is similar to vancomycin or a glycopeptide, except it is a novel semi-synthetic glycopeptide. So structure is very similar to vancomycin or teicoplanin, and the mechanism of action is similar. Just like other glycopeptides, it interferes with the D-alanine chain formation and thereby inhibiting bacterial cell wall biosynthesis. What is different about this is it has a linear dose-dependent pharmacokinetics and a really long terminal elimination phase, resulting in a half-life of 170 to 210 hours, which is really, really long. And that is why it can be dosed as once a week. So it's a 2-dose regimen, an initial dose of 1,000 milligram and a week later 500 milligram. It is renally cleared, so you have to dose adjust it for renal dysfunction. It is infusion over 30 minutes. If you give it too fast, just like vancomycin, you can get red man syndrome. And it is approved for acute bacterial skin and soft tissue structure infections, including caused by MRSA in addition to the typical beta strep or staph aureus. It's semi-synthetic, but it's similar structure. There's no data on cross-reactivity between vancomycin and or glycopeptides and dalbavancin. So what led to its approval? It was compared on a non-inferiority trial against vancomycin followed by linezolid, and it was basically non-inferior. And the way these skin soft tissue structure non-inferiority trials are done, you look at 2 outcomes. You look at 48 to 78 hours systemic response, and then you look at the size of the lesion in 48 to 72 hours. So as you can see, this was non-inferior to the usual vancomycin followed by linezolid. Pretty well tolerated. Side effects were pretty minor, nausea, some diarrhea, pruritus, and actually not much different from what is considered standard of care. So that led to its approval. The second one, similar to this, is called Oritavancin. This is again a glycopeptide, except it's a lipoglycopeptide. This is also licensed for use for the same acute bacterial skin and soft tissue infections, and it covers all those organisms. It also has activity against vancomycin susceptible Enterococcus faecalis. Not that Enterococcus faecalis usually causes skin and soft tissue infection, but it does have in vitro activity against it. What is again unique about this is the long terminal half-life, even longer than dalbavancin. So 393 hours, which basically makes it a one single dose regimen, but it's infused over 3 hours. So this was compared to vancomycin, again 2 trials looking at the same endpoints, non-inferior to vancomycin, which led to its FDA approval. So what is somewhat unusual about this drug is it has some coagulation issues. So if you do use this, for up to 48 hours after that, you cannot use unfractionated heparin because there's excess risk of bleeding. And if somebody is already on warfarin, that can increase the exposure to warfarin. So you should, use your risk-benefit judgment to decide if you must use it. And it's also hard to tease out. You can't really monitor it because it artificially prolongs the APTT and for 48 hours and PT and INR for 24 hours. So you can't rely on these testings to assess your adjustment. So that's a little unique thing about this anti-infective. So the third amongst the gram-positives is Tedizolid phosphate, which is basically a second-generation linezolid. It's from the oxazolidine class antibiotic. Again, so far approved for acute bacterial skin and soft tissue structure infections. Covers the same gamut of organisms, including MRSA, which can potentially cause skin and soft tissue infections. Also has activity against Enterococcus faecalis. This is a prodrug. It is converted by the phosphatases to Tedizolid, which is the active moiety. So this comes in 2 flavors, intravenous and oral capsule, and it's administered for 6 days. So it was compared to, since it's the second generation linezolid, it was compared to linezolid. And the way the study design was done was they used 200 milligram of Tedizolid for 6 days versus 10 days of linezolid. And this was non-inferior for acute bacterial skin and soft tissue infection. That led to its approval. Unique about this is in an animal model, if you used it in neutropenia, it was less efficacious. So if you cannot really use it in neutropenic patients and use alternative therapies. Most common adverse effects were similar to linezolid, like nausea, headache, diarrhea, vomiting, and dizziness. So so we have 3 new gram-positive drugs. So as you can see, they are convenient because 2 have extremely half-life. So it's not very clear how we should use this. You probably don't want to just give it to everybody in the ER if it's a limb-threatening infection and say, go home, you got your 1 dose, you're done. Sometimes admitting them, watching them every day gives us the luxury of observing, seeing if there's a need for drainage. So patient selection has to be careful, and you also have to weigh in the cost of these drugs, but there is a place for it for convenience. If you're seeing somebody in your office who gets recurrent cellulitis, this may have a role. The Tedizolid, the advantage is that unlike linezolid, which interferes with the MAO inhibitors, Tedizolid doesn't. So it's supposedly easier to use with less drug interactions. Some people would say, well, it's shorter duration, it's 6 days, but we don't really know how long to treat for any acute bacterial skin and soft tissue infection. Maybe linezolid for 6 days may have been sufficient. But its claim to fame may be easier to use and shorter duration. Yes?
Just the very beginning, did you make a comment at all about what the cost is currently or what the equipment is?
Probably pretty expensive. I don't know. I don't know what the wholesale price is, but I bet pretty expensive. So for the gram-negatives, so for the first time, what we have for gram-negatives is we have had beta-lactamase inhibitors combined with semisynthetic penicillin or penicillin, right? You're all familiar with ampicillin, sulbactam, Piperacillin-tazobactam. For the first time, we've been able to combine beta-lactamase inhibitor with cephalosporins, monobactams, and carbapenems. So that's something new, and there will be all these antibiotics which will get approved in the near future. And the other thing that is new for gram-negatives, we have a 4th new beta-lactamase inhibitor called Avibactam. So the first one off the block is Ceftalozone-tazobactam. So what does it add to the existing cephalosporins? There is superior anti-pseudomonal activity compared to ceftazidime. It also has activity against ESBL and AMP-C producing organisms. Remember, if it's ESBL, none of the ceftriaxones are active. So that's what is different about this. However, it's not active against KPCs or metallobeta-lactamases. So it's approved, FDA approved for 2 indications. Intra-abdominal infection, however, that has to be used in conjunction with metronidazole because it doesn't have good anaerobic activity. And it's also approved for complicated urinary tract infection, including pyelonephritis by itself. And the mechanism is similar, inhibits essential penicillin-binding proteins like other beta-lactams. So this was compared to meropenem or carbapenem, which we would traditionally use for ESBL producing organism or multi-drug resistant or cephalosporin resistant organism. and it had similar microbiological eradication rates compared to carbapenem. It is renally cleared, so there are recommendations for dose reduction in renal failure or in dialysis. However, if you look at the cure rates with renal impairment, with clearance when it decreases to less than 50, it drastically decreases to less than 50%. So even though there are recommendations for decreasing the dose, you probably don't want to use it if there's renal failure because your cure rates are going to be less than 50%. But for normal renal function, it was non-inferior to carbapenem. Avibactam is the new beta-lactamase inhibitor. It's a little different from Zerbaxa, clavulanic acid, and Tazobactam because it's semi-synthetic. And all the other beta-lactamase inhibitors are the beta-lactam ring chemical compound. This one is not a beta-lactam, it's a diazobicyclotane. And the other thing that's different is the other beta-lactamase inhibitors get hydrolyzed. This decomposes through acetylation, so it's a reversible ring. And that is why it can act with the penicillin binding, with the beta-lactamase active site and inhibit beta-lactamase degradation. So Avibactam, it will be combined with lots of different cephalosporin and monobactam and carbapenem, but first one, again, licensed is in combination with ceftazidime. So now ceftazidime comes alone or ceftazidime with Avibactam. And this has activity against ESBLs and some carbapenemase-resistant Enterobacteriaceae, and also some activity against KPC producers. So that's different from the prior one. However, if the mechanism of action is efflux pump or porine loss, then it may not be active. So you don't really need to remember that. If the phenotype is susceptible, then you can use it. But it does not have activity if the mechanism of resistance is metallobeta-lactamases, and the Avibactam does not add anything to ceftazidime against Acinetobacter, Burkholderia, or anaerobes. So those three will be unchanged. So what is it approved for? It's approved for, again, complicated intra-abdominal infection in combination with metronidazole, or complicated UTI, including pyelonephritis by itself. What is unique about this approval is, and this is part of that GAIN Act and expedited approval, is that there were no actual studies showing non-inferiority. So this combination has not been studied with any prior hypotheses. So it was, the FDA approval was based on known efficacy of ceftazidime and in vitro data of Avibactam. So the phase 3 trials are actually ongoing now, and the results will be available later, and they'll just add it as a supplemental IND, supplemental NTA. So that is why you got till those results are available, be cautious using this and use it only if you have no other alternative. So those were the antibiotics. There have been a bunch of antivirals also approved. Most of them were newer antiretrovirals and lots of hepatitis C medications, which we won't go over. But some of us in the room have probably used Peramivir during the 2010 influenza outbreak. At that time, we had to get it as a CDC expanded access compassionate use in seriously ill patients where you could not use oseltamivir because of problems with absorption, and we could get it as an intravenous use for seriously ill patients with 2009 influenza epidemic. Now it has formally been approved, except it did not get a labeling for serious influenza, which is kind of what we were using it for and needed it for. They could not demonstrate efficacy. And for other use, it's similar to other neuraminidase inhibitor where it just shortens your duration of illness by less than 24 hours. So pretty similar to oseltamivir. But it is an option for those who have trouble taking oseltamivir. You do want to remember though, it does if there is resistance to oseltamivir, should not be using this. then you want to use, I'm blanking on the name of the other neuraminidase inhibitor. This does cross-react with oseltamivir. The resistance mechanism is the same. The cost is $1,000 for a single dose. Not to be left behind, there's a new azole that has been approved, and this is quite a mouthful, izavuconazonium, and it actually is a prodrug, and it becomes izavuconazole, just like the other azoles. So it is approved for indication for both invasive aspergillus, invasive mucormycosis. What is a little different from voriconazole and itraconazole is that there's not so much variation in bioavailability. So the levels that you get is quite predictable, unlike voriconazole, itraconazole, where we have to do therapeutic drug monitoring. It does have the CYP3A4 interaction, so it's still problematic to use with other drugs, just like other azoles. There is QT prolongation, so be aware of that. There are adverse reactions similar to other azoles. There is an embryo-fetal toxicity, so do not use it in pregnancy or potential pregnancy. There is, so it was non-inferior to voriconazole, but that also means there's a 21% mortality. So these are just bad diseases. One-fifth of your patients will die, irrespective of which drug you use. So there are some advantages compared to voriconazole. Like I said, more predictable drug levels, less problems with food absorption or pH affecting its absorption. And the IV form does not have cyclodextrin, so we can use it in renal failure, and we cannot use IV voriconazole in renal failure for that reason. And it does require an inline filter, which basically means you have to handle it very gently. You can send it through the pneumatic tube. It precipitates basically, so you have to use a separate inline filter, and there has to be gentle rolling to reconstitute it. And the QT prolongation seems to correlate with increased dose, but the efficacy is not dose dependent, and that is why we don't need to do therapeutic drug monitoring. So those were the new anti-infectives through the GAINS Act in the past year. There have been some new vaccines that have been licensed. So we've had the Prevnar 13, or the polysaccharide conjugate vaccine you all are familiar with, which we have used in children since at least 2008. It was licensed for use in adults over age 50 in 2011. But there was so far there was not a recommendation to use it, because the approval was based on antibody development, that it was immunogenic in adults more than 50. But we were waiting on clinical outcome studies to see, does it really prevent invasive pneumococcal disease or decrease mortality? So that's long-awaited study from Netherlands called the CAPITA trial was now available, which did show that if those who got this Prevnar 13 compared to placebo had decreased incidence of community-acquired pneumonia of the vaccine type, and there was an all-cause reduction of non-invasive, non-bacterial pneumonia also. And if you look at the vaccine type, invasive pneumococcal disease, that decreased also. So compared to placebo, it performed pretty well. And that led to ACIP approving this, making it a recommendation to now give it to adults. So the recommendation is now to give it to healthy adults over the age of 65. And just like you give Pneumovac here, so far that's what we used to do, give one dose of Pneumovac after they turn 65. Now you give a dose of both Prevnar 13 and pneumococcal, and you have to remember the sequence. You preferentially want to give Prevnar 13 first because it's more immunogenic, and 8 weeks later give the polysaccharide vaccine. If by chance you mess it up, give polysaccharide first, or they have already received polysaccharide, then you have to wait a year before you give the Prevnar 13, because the polysaccharide inhibits immunogenicity of Prevnar 13. So now this has been updated in the immunization schedule, and you give 1 dose of each.
You say that again a little bit louder. We're having difficulty hearing.
Okay, so
Indications for the vaccine.
so there were prior indications to give it to select groups, to give doses of both Prevnar 13 and pneumococcal polysaccharide, depending on it was for those who were at the highest risk. Till now, the recommendation for healthy adults to give it age more than 65 was to give only the pneumococcal 23, right? After this study, the recommendation is to give 1 dose of each in healthy adults over 65. And the sequence is you give Prevnar 13 first, followed 8 weeks later by pneumococcal 23. If, however, you give pneumococcal 23 first, then you wait a year before you give Prevnar 13, right? The other vaccine that was approved recently is the 9-valent human papillomavirus vaccine. And so far we had 2 kinds. We had the 2-valent and we had the 4-valent. What's Gardasil is the popular name that everybody knows. And the indication was to prevent cervical cancer. So the 16 and 18 prevents about 66% of cervical cancers. The serotypes covered by this 9-valent vaccine will cover another 15% of vaccine-associated HPV. So hence the need for 9-valent. And the 4 and 9 also has some efficacy against anogenital warts. Those are the other ones it covers. So now there are 3 different types of vaccine, and you can see which vaccine-like particles are covered by these. Basically 6 and 18 is covered by all, so you got your 68% of cancer covered. These 2 are made by the same company, so it is expected that this will kind of disappear from the market soon. So what is the ACIP recommendation? The recommendation is kind of similar. The age group is the same. So routine vaccination, everybody at age 11 to 12. And you do catch up if they have not received it till the age 26 in women, 21 in men. In the past we had, for females, you could use 2, 4, and now you can use 9 also. For male, it's 4 or 9, okay? So the 9 has basically been added to the pre-existing recommendation. And we do catch-up vaccination in HIV positive or male sex with male till the age of 26. So the indications are the same, except now you can substitute it with 9-valent. Okay. So talking of yucky diseases, so this was the landmark study from 2013, which showed that if you do what is called the stool transplantation in recurrent C. diff, that leads to significant decrease in, that leads to significant cure rate compared to vancomycin, okay? So this showed that yes, that is an acceptable alternative. The study actually had to be stopped early because it was so successful. And if you look at this, this is basically the microbiota diversity that you get. So these are people suffering from recurrent C. difficile. This is the donor, and this is after your stool fecal infusion. So basically, if you can achieve microbial diversity, that is what seems to put an end to this recurrent C. diff. So this so now anybody and everybody was doing stool transplantation, including for irritable bowel disease, chronic fatigue. So the FDA kind of had to step in and say no. They finally said stool is a drug and it is a biologic agent. So if you do want to do fecal microbiota transplantation, that's a new name for stool transplantation, you have to get an IND. So what that basically means is anytime any practitioner wants to do it, they have to submit an IND as an investigational new drug and get all the IRB and the approvals to do this, which is kind of problematic because this is a difficult disease and we don't have any better solution. So they kind of said, okay, this requires IND, but we'll use discretionary enforcement. As in, we don't want you to do it without an IND, but if you do it, maybe you won't go to prison. So But for non-recurrent C. diff, for any other indication, it does require an IND, and we should not be doing it without an IND. So this is still problematic. How are we going to do it? You need to find a donor, you need to test them, their insurance doesn't cover it. So could we make it easier? And as ID physicians, we don't like procedures, so we want to make it simple so that anybody can prescribe it. So this is a proof of concept. So could we just take unrelated donors and could we put it in a capsule? And turns out in this pilot study, yes, it's possible. You can take donor stool and freeze it, and in this pilot study it was efficacious. So hopefully it will go on for development and we don't have to deal with all this. So this, in a few years, this might be the easy way of doing it. So the fun part, and this is, what's new in HIV. So we know how to diagnose. We know how to treat so that it's a chronic manageable disease so that your mortality is same as uninfected HIV. We know how to prevent it. So how are we actually doing in the United States? Very poorly. This is our report card. All right, this is what we call the CDC's cascades of care. And so of all those living with HIV, 14% don't know that they have HIV. They have never been tested. This is actually better. It used to be 80%. We have improved to 86. Engaged in care falls down to 40%, which is basically, that means linked to care and stayed in care. How many were prescribed antiretroviral? 37%. How many are virally suppressed? 30%. So you can see why there are still 50,000 new infections every year in the United States. And of those, 1 in 5 are still being diagnosed with AIDS, and the 2020 UN AIDS goal is that there should not be any AIDS in 2010. And some states are actually achieving that. So what can we do better here? So there's a big gap between the science and its application. So these were what were presented in CROI this year. These are not published yet. So CDC looked at people going to US physician office visits between 2009 to 2010. How many had an HIV testing? So we know the recommendation since 2006 is everybody between the ages of 15 to 65 should have an HIV testing. If they've never had one, no questions asked. How many got it? Less than 1%, 0.7%. Slightly higher in women, less than, even lower in men. And between 15 to 29 years, it was almost 2%, but it drops off dramatically with declining age. So physicians are still not testing, and not clear why, even though it's pretty easy to test. So that's part of the reason that part of the application, there is still this physician psychology that we got to work with. So I said we know how to prevent it. So from other studies, we know that the most effective way of preventing it is if you get viral suppression to undetectable. That decreases your chances of transmission to your partners, and whether it be intravenous drug use or sexual transmission. So in the past, we'd always talked about using condoms for prevention of HIV. Other studies have shown that if you are undetectable, adding condoms doesn't really add to it. So this is another study where they looked at how much transmission occurs with condomless anal intercourse, and turns out there weren't any link transmission if you can get the virus undetectable. And this one's confidence interval is actually 0. Prior studies, the confidence interval was wider, and that is why we would say it's low, but not 0. This one did have a 0 confidence interval, lower limit of confidence interval. So the truth is, if you have undetectable viremia, there's really almost no chance of transmission. We, however, still tell our patients to use condoms to prevent other STI. I said we have only 37% linked in care, and so how can we improve that? So this study looked at, can we incentivize them financially? So this was They had test sites in Bronx and in Washington, D.C., multiple sites. And the idea, so there was standard of care, which is, you tell them, please come to clinic, this is your appointment date. Or if they just got tested, you to give them the number and say, this is where you go for link to care. But the test arm, they got a $125 coupon if they went for a care visit within 3 months after testing positive. And for sustained care, if they could demonstrate undetectable viremia 4 times in a year, they would get $70 each visit. Okay? So surprisingly, this showed that there was no difference. The financial incentivization did not really increase overall linkage to care, and it also did not increase viral suppression. So it's not clear if this amount was insufficient or it really didn't matter. There were some sites which had fewer patients. Those sites showed some trend towards improved linkage, but even then it only increased by 8%. So this does not seem to be the answer. There have been other studies that just came out yesterday which showed that if you have patient navigators or peers which help you navigate through the system, help you with your housing, your drug abuse, those seem to work much better. But this answered the definitive question of probably financial incentivization probably does not make a difference. So I said we know how to prevent HIV infection. And the way we know how to prevent that, there have been multiple randomized controlled trials which show that if you're at high risk for acquiring HIV, if you take 1 pill a day, a tenofovir emtricitabine combination, that substantially decreases your risk for infection, anything between 86 to 93%, better than any vaccine we could potentially have. The critics of those studies said, well, that's true, but those were done in a randomized control trial where they were blinded to what they were getting. If they know they're taking a medication which decreases their risk, they may engage in high-risk behavior and there will be actually increased risk. So this study was done to see, well, let's test that hypothesis, is this true? So this was done to mirror real life. So people, who would be candidates for pre-exposure prophylaxis, they were randomized to, this was open label, so they knew which arm they were in. So one arm got immediate pre-exposure prophylaxis, one arm was in a deferred arm for a year. And then they were observed to see how many HIV infections occur. So the arm which got in the deferred arm, who were still waiting, there were 19 infections, even though there were 174 prescriptions for post-exposure prophylaxis. There were still 19 infections, while in the immediate arm, there were only 3. So there was a relative risk reduction of 86%. And this led to the Data Safety Monitoring Board saying, stop the study early, and the deferred arm were put on pre-exposure prophylaxis. So this finally answers that question that in real life too, pre-exposure prophylaxis does substantially increase the risk, and we should be offering it to those at highest risk. And there was no increased risk of STI in the arm which got pre-exposure prophylaxis. So the problem with these pre-exposure prophylaxis is, the way these studies were done and the labeling is you got to take 1 pill a day every day. If you take those pills less than 4 times a week, it's as good as not taking it, because if you don't have detectable tenofovir levels, it's not protective. So everybody knows it's pretty hard to take a pill a day, and the times it doesn't work is because they're forgetting to take their pill. So can we make it easier? So this study looked at how can we make it easier, can we do it on demand? So this was, so those at high risk, MSM, and who had history of condomless sex act, the renal function has to be normal because of the tenofovir that we use. We can't use it for impaired renal failure in this dose. They were asked to take 2 pills of this same medication or placebo 2 to 24 hours before each sexual intercourse, and then another one 24 hours later and 48 hours later. And then you kind of follow them and see how many HIV infections occur. And there was a placebo arm. This was blinded. There was placebo and there was this medication. And this again showed with this on-demand strategy, there was a 86% relative risk reduction. So there were 2 infections in the tenofovir FTC arm and 14 in the placebo arm. And when they looked at those 2 people who did develop the infection, actually, I'm not sure what happened to those people because it's not published yet. They didn't say. So why those 2 people developed infection. But there is a 86% reduction. So right now, this is not ready for prime time, but this does show another way of approaching this question of pre-exposure prophylaxis. So right now, we know that if we identify everybody who has HIV, put them on antiretroviral therapy, get them undetectable, that will significantly decrease the transmission. But it does take about 6 months to get them to undetectable after they start taking their antiretroviral. We give them 6 months to become undetectable before we call it virologic failure. So their partners are still at increased risk for those 6 months. So right now, PrEP is offered to those who are at high risk, who are not in a monogamous relationship, have multiple partners. There was no data to show, because the risk of transmission is so low if they're undetectable, would there be any benefit to giving these people PrEP? So this was designed to study for those first 6 months while we are waiting for them to achieve viral suppression, is there a role for PrEP in their negative partner? And this showed that the expected incidence in those negative partner was thought to be 5.2 per 100 person year. But when they put the negative partner on PrEP, there were only 2 incident HIV infections. So the incidence was down to 0.2 per 100 person years. So 96% decrease above what was expected. The 2 people who did seroconvert, the 2 partners, they had undetectable plasma viremia of tenofovir. So they were obviously not taking their medication, and that is why PrEP failed. So again, highlighting that it works only if you are able to take it at least 4 times a week, preferably every day. So that this gives us another population where there's a role for PrEP the first 6 months in a monogamous relationship in the negative partner, which was not an indication before. So the psychosocial physician patient and its application is what is basically new in HIV. And that is all I had. Any questions?
I'm sorry if I missed this. We're talking about the neuroimmunity vaccine. If you have say a teenager has a virus, has a strong administration, or is there any guideline that?
No, that's a great question. No. There's no, since it's so new, it wasn't studied in that scenario. All these approvals are based on decreasing the CIN. The outcome's not really cancer. It's expected you decrease CIN and that will decrease your cervical cancer. It does seem to, so the answer is no, we don't know that. There is no recommendation to give more than 3 doses in anybody. And you don't have to restart or give them the 9-valent if they have already received or completed their prior course. And there's no recommendation to even switch. Say they got 2 doses of the 4-valent, you don't necessarily have to switch to 9-valent. If the 4 is not available, then you can. So the long-term data and the natural history of how these affect cervical cancer is still being studied, and that is why you still have to keep doing cervical cancer screening. That's a great question, but unanswerable at this time.
You have pre-exposure trials with Truvada. There weren't many that developed HIV, but if you did, and were only taking the Truvada intermittently, would there be a problem in developing resistance? Has anyone looked at that?
Oh, actually, that was looked at in those PrEP studies, and there were less than 1%, I forget the exact number, maybe it was 0.7, who did develop resistance to emtricitabine, the one who got the PrEP. But when you compare that to how many people have transmitted drug resistance, the number is actually 13 to 16% in the United States. So the risk of the resistance seems to be pretty low and much less than naturally acquired without pre-exposure prophylaxis, HIV acquisition and transmitted drug resistance. And they were mainly to emtricitabine. There was one which was due to tenofovir, but those are easily handled with our current antiretroviral. And on these newer studies, they haven't talked about the resistance, but the prior ones was pretty low. But that is a reason to not prescribe more than 3 months at a time. You don't just prescribe and say go home and keep taking it. You never prescribe more than 3 months. You have to be, if there's any suggestion, you have to test for acute retroviral so you detect it early. And in that pre-exposure prophylaxis and all those trials, if there was a risk of significant exposure, you still give them post-exposure prophylaxis. So it's not just pre-exposure. You do pre-exposure, but add post-exposure prophylaxis if there is, say, high-risk condom breakage or IV drug injection from somebody who's positive. Yeah, it is a concern, but way less than what we normally see. Anybody else?